Welcome to this rapid, high-yield clinical explainer on metoclopramide. We're going to strip away the fluff and take this straight from basic receptor science right to patient safety. Let's get right into it.
Here is our clinical roadmap. We'll be hitting central dopaminergic pathways, pharmacodynamics, physiological effects, contraindications, risky interactions, and finally, adverse effects. Section 1. Central dopaminergic pathways. First, we need to map out the anatomical foundation. Looking at the brain here, you can see the 4 primary dopamine pathways. For your clinical practice, you need to pay incredibly close attention to the nigrostriatal and tuberoinfundibular pathways. Why? Because they are the exact anatomical sites where our most severe side effects are going to originate.
This breakdown right here is absolutely high yield. Blocking dopamine in the chemoreceptor trigger zone, the CRTZ, is exactly how we treat vomiting. But here's the catch. Metoclopramide is not selective. That same blockade hits the limbic system, affecting schizophrenia, it hits the basal ganglia, inducing Parkinsonism, and it targets the pituitary gland, causing hyperprolactinemia. You simply cannot get the therapeutic good without the risk of the bad.
Section 2. Pharmacodynamics. Let's zoom in on how this drug actually behaves at the receptor level. Metoclopramide hits the body with the dual action. Centrally, it blocks D2 receptors right in the area postrema, which gives us our antiemetic effect. But peripherally, blocking D2 actually lifts the normal dopaminergic inhibition in the gut. This triggers a massive release of acetylcholine, resulting in a very strong prokinetic effect. And it doesn't stop at dopamine. It also acts as a 5-HT4 agonist, further stimulating cholinergic neurons to ramp up gut motility. Plus, at high doses, it becomes a 5-HT3 antagonist, essentially blocking those vagal nerve signals. That specific mechanism makes it a fantastic weapon against chemo-induced nausea.
Section 3. Physiological effects and indications. So, what do these receptor interactions actually do to the patient's GI tract?
As this schematic shows, that acetylcholine release drives 3 major mechanical changes. It increases the lower esophageal sphincter tone to fight off reflux, it relaxes the pylorus, and it dramatically accelerates gastric emptying. Because of these targeted effects, we use it for chemo and radiotherapy nausea, migraine-associated nausea, and post-op vomiting. Furthermore, that aggressive prokinetic action makes it a reliable go-to for diabetic gastroparesis and severe GERD, basically mechanically forcing the stomach to empty.
Section 4. Contraindications and precautions. Knowing exactly how it works also tells us exactly when it's dangerous. You must memorize these absolute contraindications. Do not use it if there's GI hemorrhage, obstruction, or perforation. Because it penetrates the central nervous system, it is strictly off-limits for patients with Parkinson's, epilepsy, or a history of neuroleptic dyskinesia, and absolutely no use in infants under 1 year old or in patients with a history of methemoglobinemia.
For adults, there's a strict golden rule to follow. Treatment must never exceed 5 days, and the maximum dose is 30 milligrams daily to limit those severe neurological risks. You've also got to monitor closely for QT prolongation and bradycardia, and always adjust your doses for patients with renal or hepatic insufficiency.
Section 5. Risky drug interactions. This brings us to a vital pharmacological concept you cannot ignore.
We need to talk about reciprocal antagonism. If you combine a dopaminergic agent with metoclopramide, they essentially cancel out each other's therapeutic benefits. But the problem is the adverse risks actually multiply. This mechanism makes it an absolute contraindication. Look at this chart. You literally never mix metoclopramide with levodopa, ropinirole, or other dopamine agonists. Also keep in mind your extrapyramidal risks shoot way up if you combine it with lithium or neuroleptics. And watch out for strong CYP2D6 inhibitors like fluoxetine or paroxetine. They will spike the drug's concentration in the blood and severely increase the risk of QT prolongation.
Section 6. Adverse effects and monitoring. Finally, what should we be looking out for when we prescribe this? Because it aggressively crosses the blood-brain barrier, issues like extrapyramidal syndrome, Parkinsonism, and extreme drowsiness are quite frequent. Less common, but absolute emergencies to watch for are hyperprolactinemia, QT prolongation, and neuroleptic malignant syndrome. For your pregnant patients, you must monitor the newborn very closely, and lactation is generally not recommended.
Let's wrap up with a quick clinical scenario. You have a Parkinson's patient suffering from severe nausea while taking levodopa. Based on the reciprocal antagonism and central D2 blockade we just covered, why is prescribing metoclopramide here a critical, potentially fatal error? Think about it. Mastering these foundational mechanisms is exactly what guarantees your patient's safety on the floor. Thanks for joining this clinical explainer, and I'll catch you next time.